behavioral neurologist who has training in aging and dementia, as well as statistical genetics and epidemiology. He is an associate professor of neurology at BU, where he also directs the Alzheimer's Disease Center Clinical Core and also helps to lead the UNITE study, which he'll be talking about today. He is the PI of multiple NIH and DoD funded grants, many of them studying the relationship between repetitive head impacts and TBI on later life neuropathologies and associated clinical correlates. So today he will be talking about the UNITE Brain Bank and where we are with clinical symptoms, presentation, and diagnosis. So I will turn it over to you, Dr. Mez.
All right. Thanks so much, Mike. All right. So today, like Mike said, I'm going to talk about some recent updates from research we've conducted in our UNITE Brain Bank, which is of folks who have a history of exposure to repetitive head impacts, either from contact sports or military service or physical violence. And this talk is a little difficult to give at BU because we have so much going on with CTE that my typical canned talk is everybody already knows everything that I'm going to say. So here I tried to focus on 3 papers that we've either published or in submission right now, and hopefully it'll be a little bit more unique from some of the things you've heard from other investigators in our center. That being said, if you've heard me talk over the years, these are studies that have been years in the making, so I have probably spoken about them before, but hopefully this is new to most of you. All right. Let's see. Okay, there we go. I don't have any disclosures. So here is the outline. I'll give you a brief overview of the history and neuropathology of CTE, just for those who are less familiar. And then I'll talk about 3 manuscripts from the past year, duration of football play and CTE, which we published, I think, in January of 2020 in Annals of Neurology. And then these second and third papers, Validity of the 2014 Traumatic Encephalopathy Criteria for CTE Pathology, is currently under submission. We just got some nice reviews, so hopefully that will be published soon. And then this last paper, Structural MRI Profiles and p-tau correlates of atrophy and neuropathologically confirmed CTE, is a paper that we also have in submission, which I worked closely on with Mike and others in our center, and which we're excited about too. So I'll talk a little bit about that as well. And then I'll tie that into some of our previous work too, and how it led to these papers. All right, so very briefly, for those who know less about CTE or chronic traumatic encephalopathy, while it's gotten a lot of attention recently, and is to some, it seems like a newly described disease. It's actually been described for years. It was first described as punch drunk by Martlin in 1928. The term chronic traumatic encephalopathy was first coined by Critchley in 1949. These studies were all in boxers, and at the time it was thought to be a disease exclusively of boxers. Really quintessential case series of neuropathologically confirmed CTE, all boxers, was published by Corsellis in 1973. And then CTE started to get a lot more attention starting in the mid-2000s when Amalu presented case reports of CTE in NFL football players. And then Dr. Ann McKee, who is the PI of the Brain Bank, a lot of the data that we're presenting today comes from the UNITE study, of which she's the PI. So she presented a case here, a case review of all of the neuropathologically confirmed cases in 2009. And between the Amalu cases and this review paper, CTE got a lot more attention. So very briefly, reviewing the neuropathology of CTE. So this paper from Brain in 2013 lays out some of the quintessential components of the neuropathology. This was a case series of 50 some from the same Unite Brain Bank, the early cases. And what Dr. McKee described was a pathognomonic lesion of tau pathology surrounding blood vessels. It's this patchy distribution. It tends to be at the depths of the sulci. So while tau is a common component of many different neurodegenerative diseases, including Alzheimer's disease and other frontotemporal lobar degenerations, this pathognomonic lesion of perivascular tau at the depths of the sulci is only been seen in CTE. And in that same paper, she described a staging system, 1 to 4, characterizing the severity of the tau pathology, beginning early deposition is in the frontal lobe, especially the dorsolateral frontal lobe, and then progresses to involve the temporal lobe and the parietal lobe. And then by stage 3, there is involvement of medial temporal structures. And then by stage 4, there is diffuse pathology. And she also described that the pathology seems to follow an age distribution with increasing stage and increasing age. So this paper from 2016 was a validation of those diagnostic criteria for CTE. And what this paper did is it brought together a number of really experts in the field, neuropathologists on tau pathology, and they looked at a number of different tauopathies and differentiated them individually by looking at the different cases. And then we looked at the relationship about how well they agreed across the different diagnoses. And what we saw was that these senior neuropathologists actually agreed as much or more for CTE diagnosis compared with some of these other tauopathies, again, including Alzheimer's disease, progressive supranuclear palsy, corticobasal degeneration, et cetera. So it was another way of validating these criteria. And out of this paper came this statement you can see at the bottom, basically just reaffirming that this perivascular tau lesion is pathognomonic. So then this paper led by Mike came out this year in Acta Neuropathologica, and it was similarly a way to validate the staging system that was proposed in that Brain paper from 2013. And what we did here was we looked at quantitative tau pathology. So rather than having the neuropathologists say how much tau was there in the regions, we took this objective approach where we used digital slide scanning. And we compared that tau in the regions we commonly see in CTE to the staging system as determined by the neuropathologists. And we saw this nice relationship with increasing tau pathology in these regions and stage. And similarly, we saw again that the staging correlated with age. And we also saw increasing dementia frequency. with increasing stage. So this was a nice validation of the staging criteria too. All right. So now I'm going to go on to these 3 papers. So we'll start with the duration of play paper, and here repetitive head impact exposure and risk for CTE. I'll give you a little bit of background and then focus on the first of those papers. So this is the distribution of CTE and by repetitive head impact exposure in our Unite brain bank. And you can see that it spans many different contact sports as well as military service. And you can see that CTE is really common among individuals who have played substantial contact sports and have substantial exposure, at least in the setting of our brain bank. And I'll talk about this more later, but we really don't have a sense at all of how prevalent this disease is in the general population among those who do have exposure to repetitive head impacts. But this does at least suggest that substantial exposure to repetitive head impacts in the form of contact sports mostly does seem to predispose qualitatively to CTE. And so this is a really nice paper that establishes this relationship more quantitatively from Kevin Bieniek from 2015. And this was in a neurodegenerative disorders brain bank. So, you know, not at all related to exposure in order to get into the brain bank. This is mostly folks from their Alzheimer's disease center and related studies. So most of the folks in this brain bank probably were symptomatic and had different neurodegenerative diseases. So again, not completely representative of the general older population, but still selection wasn't at all related to exposure to repetitive head impacts. And what they did is they started with their 4,000 brains. They looked at the men to get them down to 2,500. They restricted their analysis to those who did not have other types of tauopathies. Then among these 1,700, they went through their obituaries and their yearbooks and identified 66 of them who had played contact sports. And then they looked at the neuropathology among those 66, and they saw that 21 of them had CTE pathology, while 45 did not. And then they looked at a matched group by age from the non-athletes. So 2 to 1, 132 men who did not play contact sports. And what they saw is that none of these men who did not play contact sports had CTE, while 21 of the 66 who did have evidence of the pathology. They also saw that among individuals who had a history of single TBI, none of them had CTE either. And while they didn't do a statistical analysis, this descriptive, I mean, you can see for yourself, and if you actually do plug it in and do a quick 2x2 table, you can easily see that what they found would be very unlikely to happen by chance. So this is a really nice paper linking contact sports to CTE in a kind of a non-biased approach. So then, based on what we see in our brain bank and what Kevin Bieniek found in this paper, it seems like there's really good evidence that repetitive head impact exposure, especially contact sports, is is related to CTE pathology. And then this is from a review paper that we published in 2017. And what we saw was that among 202 folks from our brain bank, we saw that as level, these were all football players, as level of play increased, the frequency of CTE increased. And then similarly, among those with CTE, as level of play increased, we saw an increase in severe CTE, so stages 3 and 4. And I mean, it's important to note here. So, for instance, 110 out of 111 of the NFL players had CTE in our brain bank. That certainly doesn't mean that that NFL players have a 99% chance of developing CTE. There's clear selection bias into who gets into our brain bank. Just as with any brain bank, those who are symptomatic, their family members want to know what was going on, are more likely to donate. But it nonetheless does suggest that there seems to be this dose-response relationship. With the more that you play, the more likely you are to get disease. So we took this a step further, and we made the hypothesis that years of play, the more football that you play by years, would be associated with risk. And the idea was that we really wanted to get a good sense, we really wanted to be able to quantify how much exposure is needed to really be at risk for the disease. If you had some way of quantifying it sufficiently well, then it could really help in terms of diagnosing CTE in life and helping clinicians predict whether somebody who has a lot of exposure might and is having symptoms might have the underlying pathology. So here we started with 404 from the Unite Brain Bank, as well as 222 from the Framingham Heart Study Brain Bank. We excluded those who didn't play football, and we excluded individuals who were under age 20, as we wanted the age distribution or the age range to be the same for those with and without CTE. And we ended up with 266, 223 of which had CTE. They were all from our Unite or VABU CLF, same thing, brain bank, and then 43 who were from either Framingham or from the Unite Brain Bank. And if we look at the characteristics of these folks, we see that all of them were men, that about 80% were white and 17% Black. And we see that the mean age is about 61. And when we look at the mean age between cases and controls, they're actually quite similar, but we see an increasing age, as I mentioned before, with increasing severity of CTE. And then we see a similar increasing likelihood of CTE with each level of play, like I described before. Another important point just to make here again is this selection into the brain bank. So of the 130, that's missing, but you can see that 50% were professional players and 30% were college players. So 80% of the folks we were studying were high level players, so either college or professional, which is very different than the distribution of play that you see in the general population of football players. So most folks have played at the youth level or the high school level. There's far fewer who play at the college and professional level. So understanding how that may bias the relationships that we're measuring is an important component. All right, so here is the distribution of duration of play by CTE status. And what you can see is that among those who did not have CTE, they played anywhere from 1 year up to about 18 years, with a mean of about 12 years. Sorry, of about 7 years. And then if you look at those with CTE, again, they played as few as 1 year and as many as about 32 years. And actually, these folks who only played a couple of years also played other contact sports. So it wasn't as if they had only played football. And then the mean number of years was about 14, I think. And what we saw is that the odds of CTE increased by 30% for each additional year played. And this equates to a doubling of odds every 2.6 years. And this was unlikely due to chance alone. And similarly, you can see the distribution here on the right of those with mild and severe CTE. And again, we saw that so among those with CTE, the odds of developing severe disease increased by 14% per year. And that equated to a doubling of odds every 5.3 years played. And using an receiver operating characteristic curve, we can look at the area under the curve, 0.84, and see that duration of play is a good predictor of CTE pathology. And then we can also look at the likelihood ratios. So likelihood ratios give us a good clinical sense of whether a piece of clinical information can help us make predictions or guide clinical management. And there's a rule of thumb that a negative likelihood ratio of 0.1 and a positive likelihood ratio of 10 start to give us sufficient information that we can make clinical decisions. And what we see is that compared to those without CTE, those with CTE were 1/10 as likely to have played fewer than 4.5 years. And so that's a likelihood ratio, a negative likelihood ratio of 0.1. And similarly, compared to those without CTE, those with CTE were 10 times as likely to have played greater than 14.5 years. So that's a positive likelihood ratio of 10. And then when we maximize the sensitivity and specificity, that was at 11 years of play. And these cutoffs, and I'll talk about this a bit more later on, have been incorporated into criteria that we're developing to diagnose CTE in life. So another important component of this paper was looking at this selection issue and whether it was biasing the estimate of the association that we were measuring. So there's been a lot of work on selection bias and how selection might bias an estimate that a relationship that we're estimating. And what we've learned is that the only time that selection will bias a relationship is if both the predictor and the outcome are differentially associated with selection. So in the case of the relationship that we're looking at here, if we knew how years of play was related to selection, and if we knew how CTE disease status was related to selection, then we could incorporate those relationships into our modeling and get a better estimate of what this relationship is. And we can do that using inverse probability weighting. The problem here is that we actually don't know this relationship. So while we know the distribution of years of play in our brain bank, we don't know what the distribution of years of play is in the general population of football players. We looked really hard for that. And while we know how many people play football in the general population, we don't have any sense of their years of play. And similarly, we know the prevalence of CTE in our brain bank, but we don't have any good sense of what the prevalence of CTE is in the general population of football players. So we're kind of stuck, and we can't use a traditional inverse probability weighting to deal with selection. But even though we don't know this relationship, we can come up with a reasonable range of what that relationship might be. And so this is actually what we did. We did a simulation analysis where we took the whole range of values that this relationship could reasonably be. And similarly, we took the whole range of values that this relationship could be. And we repeated our regressions thousands of times, waiting for each of these different relationships in a simulation. And what we found is here. And basically that across all of these reasonable relationships between years of play and selection and CTE disease status and selection, our relationship between years of play and CTE disease status did not change substantially. So the entire range, you'll recall that there was a 30% increase, or an odds ratio of 1.3 was the relationship that we measured. And so we never got to an odds ratio of 1, and the lowest we ever got was 1.22, and it went up to as high as 1.4. And you can see here that for substantial selection, so on the order of, for each additional year played, we were 50 times as likely for a brain donor to donate. And similarly, for somebody with CTE, they were 50 times as likely to donate as those without CTE. These relationships only changed slightly. So this is a really nice evidence that selection bias, or selection, is not biasing this relationship that we're measuring between years of football play and CTE disease status. So some additional findings from this paper. We looked at several other components of RHI exposure. So concussion number, age of first exposure to football, whether other contact sports were played, primary football position. This was just dichotomized as linemen or non-linemen. And none of these were nominally associated with our primary outcomes, and we left them out of our final models. That's not to say that if we looked particularly carefully at these values or collected more data in a different way, that they might not also be contributing to CTE. Our goal here was really to look at the relationship between duration of play and CTE. So kind of leaves to future studies to get at some of these other potential risk factors more carefully. We also conducted sensitivity analyses where we took out any individuals who had comorbid neurodegenerative disease, as well as those who played other contact sports, a couple other sensitivity analyses that the reviewers asked for. And when we still saw these same relationships. And then important limitations from the study were that we were only able to estimate these relative relationships. So a 30% increase with each additional year played, but we can't say what the absolute prevalence of CTE is in the general population of football players for a given year amount of play or a given years of play. And you really need an epidemiological population-based study to get at that. And that's something that's really critical that we still need to learn about this disease. And then another clear limitation was that we really focused on the relationship between duration of play and the pathology. And you know, the relationship between pathology and symptoms is another complicated relationship that we're still trying to understand. And because we were really trying to focus on this years of play pathology relationship, we stayed away from clinical symptoms, but understanding that relationship is still important. And for next steps, like I said, we're incorporating those cut points into updated traumatic encephalopathy syndrome criteria to diagnose this in life. We're taking a similar approach in hockey, where we now have enough folks in the brain bank to make similar estimates. And then we're also extrapolating position and level specific helmet sensor data onto our brain donors. And then that will help us make better inferences about position, number of hits, force of hits. And we did something similar like to this in living individuals. The chi is what this paper from Montenegro et al. In 2017 looked at. So we're going to do something similar. We're doing something similar in the brain bank as well. All right, so now I'm going to move on to diagnosing CTE in life. Here are individuals from the brain bank. Their families have authorized us to show their picture. Their pictures sort of help tell the story of who they are and make their clinical history a bit more personal. So a good way to start here is to look at this review paper from Bob Stern and Phil Montenegro was the first author here, where they looked at every case of neuropathologically confirmed CTE and grouped the symptoms that were described into either behavioral features, mood features, cognitive features, and motor features. And what they found is that those at the top of each of these lists were found in 70% or more of the cases described in the literature. So the most common here are the explosivity and loss of control, depression and hopelessness, memory impairment, executive dysfunction impairment, and gait disturbance and Parkinsonism. So then Bob Stern also published this paper in 2013, where he went to 36 former athletes from the brain bank who had pure CTE. And he interviewed, and when I say pure CTE, I mean those who did not have other neurodegenerative diseases. And he interviewed family members of the deceased and qualitatively described the syndromes that he heard. And what he found was that they fell into two groups, a behavior and mood group and a cognitive group. And the behavior and mood group initially presented with behavior and mood symptoms, the depression, the short fuse. They tended to present with symptom onset early in their 30s, and they passed away in their 50s in general. And most of those folks started with the behavior and mood symptoms and went on to develop cognitive symptoms as well. And then he described a second group who started at, whose age of symptom onset was later, around age 60, and they passed away closer to age 70, and they were less likely to have the behavior and mood symptoms. So based on that review of the literature and that careful case series, we proposed criteria to diagnose CTE in life back in 2014. We called those traumatic encephalopathy syndrome criteria. And the thinking on these criteria has changed over the years, but back in 2014, we thought it was important to characterize all the clinical outcomes that happen from repetitive head impact exposure. And here we were really focused on the chronic outcomes. But it wasn't necessarily the case that this was specifically CTE pathology that was driving the syndrome. And now we have the sense that it's probably better to really focus on the underlying pathology. But nonetheless, this was something that we were thinking of at the time. The other piece is that this was a first attempt at creating these criteria, and they hadn't been validated, and they were really not meant for clinical use. They were really meant for research use. So I'll just walk through these particularly quickly. You needed to have a history of repetitive head impacts. You needed to have at least one core clinical feature. And these core clinical features were driven by those clinical components that were present in that review paper at least 70% of the time. So they could be cognitive symptoms, specifically memory, attention, and executive dysfunction, behavior, having the short fuse, and mood symptoms, specifically depression. And you needed to have at least two supportive features, which are listed here. You needed to have clinical features for at least a year. And then there were subtypes and modifiers. So was it cognitive, mood and behavior, or a mixed presentation? Did they have dementia? Were there motor features? And what was the clinical course? Was it stable, progressive, or inconsistent? And then we talked about the likelihood of CTE pathology. And because CTE is thought to be a neurodegenerative progressive disease, you needed to have a progressive course in order to meet these criteria for possible or probable CTE. The other piece here was that there was a nod to biomarkers in the way that we use biomarkers in Alzheimer's disease, even though there weren't biomarkers present at the time, and even now, that allow us to identify the underlying pathology. So perhaps it was a bit premature to put them in the criteria back then, but those biomarkers were how we distinguished in the criteria between possible and probable CTE. So we wanted to validate these criteria. And so we proposed these methods in 2015 to apply these criteria to our brain donors using a more structured approach where we still interviewed the family members and then applied these criteria to see how well they predicted the gold standard CTE pathology. And here's a summary of what we did since 2015. You can see the inclusion criteria for our brain bank, for the Unite Brain Bank here. What you see is that in order to be included in the brain bank, you need to have extensive exposure to repetitive head impacts. So either in the form of college or professional contact sports, military service with RHI exposure, or domestic violence. And we do have a particular interest in those who have passed away early. They provide a unique insight into what the mechanism is that may be driving CTE pathology. So we did relax the criteria for them. So those under age 35 could have any amount of repetitive head impact exposure. And we have two parallel pathways for this approach. We have a clinical protocol where clinicians would speak to family members of the deceased and collect information in the way that we would do at a memory disorders clinic. And then our neuropathologists would review and make a look grossly as well as microscopically and make a neuropathological diagnosis. And the clinicians were entirely blinded to the neuropathology. The neuropathologists were completely blinded to the clinical information. Then once we finished this process for each brain donor, we brought them to a consensus conference where we had an expert panel of behavioral neurologists, neuropsychologists, neurosurgeons with expertise in TBI, psychiatrists, and we applied the TES criteria and the TES subtype criteria. And then we also diagnosed other disorders that we saw. So we've now done this for 336 brain donors, and I'm going to describe what we saw. So we here are the demographics and the other head trauma related characteristics of the brain donors. You'll see that most of them had contact sport exposure. Most of them played football. We saw a demographic distribution similar to what I described previously. And here you can see a breakdown of the numbers in terms of their TES CTE diagnosis and their CTE pathological diagnosis. You can see that 72% had CTE pathology, and 92% were diagnosed with TES CTE. And so the criteria are particularly broad. The idea back when we wrote them in 2014 was that they were supposed to be sensitive more than specific, and that's very much what we found. So we were quite accurate, or relatively accurate, 76%. And the criteria were very sensitive. So just about everyone with CTE, we diagnosed with CTE. However, the criteria were not particularly specific. So we diagnosed, among those without CTE, we diagnosed a lot of them with TES. And we were, the criteria were reliable. So the raters at the consensus conference agreed most of the time. And here is a breakdown of those that we got wrong, the false positives and the false negatives. Most of the false positives either had cerebrovascular disease or another neurodegenerative disease. Most of the false negatives had low stage CTE. So these are folks who did not meet TES criteria but did have CTE pathology. So most of them had low pathology, which might not have explained their clinical syndrome. And then you can see some of the pathologies that we observed here. You can see CTE pathology in the top left. So we found individuals with Lewy body disease, with plaques and tangles, with infarcts, and with arteriolosclerosis is what you see here. And I'm going to keep moving because I'm starting to run out of time. When we looked at individual components of the TES criteria, what we found was that cognitive symptoms were particularly predictive of CTE pathology, but the behavior and mood symptoms were not predictive, nor were the motor symptoms. And then we also saw that if symptoms were present for more than 12 months, they were also predictive of pathology. And what we did is then we went back and said, because cognitive symptoms seem to be particularly predictive of the pathology, that what if we recategorized the brain donors and said you needed to have cognitive symptoms in order to meet TES criteria. So those who just had mood and behavior symptoms were recategorized as not having TES. And when we did that, we found that our accuracy did not change at all. Our sensitivity remained good. It was still around 90%, and our specificity increased from 20% to 40%. So that was a pretty marked improvement. And then if we were to compare that to the clinical diagnosis of AD prior to the use of biomarkers, we see that our specificity is now at least in the neighborhood of what we see with Alzheimer's disease. So this insight that cognitive symptoms are particularly important for predicting pathology is also being incorporated into these updated TES criteria. So here are just a summary of our findings from this study. So the TES criteria were accurate and sensitive, but had low specificity. So they are good for ruling CTE out, not as good for saying that CTE is in fact there. The specificity improved with inclusion of cognitive or requirement of cognitive symptoms. The study was limited by our retrospective design. Obviously, if we could have followed these individuals in life prospectively, that would have been ideal. The study would have obviously taken many, many years longer. We had because it was this retrospective study, we had inconsistent information about neuroimaging, biomarkers, neuropsychological testing. So it's certainly reasonable that given we didn't have that information, that diagnoses weren't as accurate. And I'll skip this last one. And this information, both the exposure information, those cutoffs that I described in the first paper, as well as this insight that cognitive symptoms are particularly important, are being incorporated into a new set of criteria. And we had this first NINDS consensus workshop in Arizona in 2019 to create a new round of criteria. And this effort is being led by Doug Katz and Bob Stern. And there's a picture of all of us when we could be close to each other. And we used actually modified Delphi technique, and I won't walk through what that means, to create new criteria, but they were largely informed by some of this data that I've been presenting today. And we actually have a manuscript separate from the one I just presented on these new criteria that are also in submission and have gotten a positive review as well. So we're optimistic that both of these papers will get published soon. And even though these new criteria haven't been published yet, we've actually begun incorporating them into several of our studies, including Diagnose CTE, our ADC clinical core, and our neuropathology studies in Unite and U54. All right, so in the last couple of minutes, I am going to talk about MRI and our last paper. So MRI is a really critical part of the general clinical workup for neurodegenerative disease. We order an MRI in our memory disorders clinic on every single patient, essentially, who comes through. So knowing the patterns that we see on MRI in different neurodegenerative diseases, including CTE, is a really critical component for diagnosing neurodegenerative disease and CTE specifically. MRI is also critical for outcomes for our large-scale multi-center clinical trials for disease-modifying therapies. When we look at MRI, so that being said, MRI has never been studied in CTE among those with neuropathologically confirmed cases. And that's largely because we haven't gathered enough scans and enough folks haven't passed away to study in an organized way. That being said, MRI has been studied among individuals at high risk for CTE, so elite former athletes, especially football players and professional fighters. And what we see in those studies is that there is frontal and temporal atrophy, that there is medial temporal atrophy, that there's a greater burden of white matter pathology, and there are higher rates of cavum septum pellucidum. And like I said, these studies all lacked gold standard assessment for CTE neuropathology. So they were assessing individuals who were at risk for CTE, but didn't necessarily have the disease. So these findings were nonetheless largely consistent with what we see neuropathologically. So here you can see a cavum septum pellucidum. This is the separation of the septum between the lateral ventricles. This isn't a specific finding to CTE. We see it commonly in the general population on MRI, but there is evidence that this might be happening more frequently in CTE. And it's very possible that this isn't related to the tau pathology per se, but rather to the trauma. We also see atrophy, not shown that well here, but most commonly frontal and temporal atrophy. We see expansion of the ventricles. This is, again, not specific to CTE. With atrophy, you see increased ventricle size. One thing we do see in CTE that might be different than Alzheimer's disease is an expanded third ventricle and an atrophy of the thalamus, and that really hasn't been described in Alzheimer's disease. We commonly see medial temporal atrophy. Again, this seems to be later in the disease course. Recall the tau pathology seems to hit the medial temporal structures in stages 3 and 4. This is the third paper that we also have in submission. So the idea here was that we went back and looked at images that we were able to gather from our brain donors and compare them to individuals who had normal cognition. And so we started with clinical MRIs from our Unite Brain Bank. And then we compared them to folks with normal cognition from our ADC clinical core, as well as the Framingham Heart Study. And these were all clinical scans. So we couldn't apply our typical approach where we use software and automate the quantification of volumes and white matter pathology. So we needed to have neuroradiologists do this. So we had 3 neuroradiologists visually rate these MRI scans, both for regional atrophy, for white matter hyperintensities, and for cavum septum pellucidum. And we also looked at the relationships between regional tau pathology and the amount of atrophy. And here you can see a breakdown of where we got our participants from in the brain bank. So we started with 863 total brain donors, but it was quite a process in order to find scans from the medical records to actually get the disc, to have, then we further limited the analysis to those who were older than age 60 in order for our age range with our comparison group to be the same. Also, we were really interested in those with later stage CTE who would have more marked atrophy, so that we could better understand the differences. So we ended up with 55 individuals who had an MRI that we could review and who had neuropathologically confirmed CTE. And we compared them to 31 with normal cognition. And you'll actually see that the age of MRI scan was older among those with normal cognition than our CTE brain donors. Almost everyone was white. There was about a 4-year difference between the time of the MRI scan and the age of death. And what we saw was that very much what we'd expect to see, but the fact that we were able to confirm it in those with neuropathologically confirmed CTE was still pretty striking. So we saw differences in atrophy in the medial temporal lobe, the anterior temporal lobe, dorsolateral frontal cortex, the orbital frontal cortex, and superior frontal cortex. But we didn't see differences posteriorly in the parietal occipital lobes. And these are an area that we typically see atrophy differences in Alzheimer's disease. In addition, we saw differences in volumes of our lateral ventricles, or not our radiologist ratings for the lateral ventricles and the third ventricle, as well as for cavum septum pellucidum. So they were more than 6 times as likely to have a cavum septum pellucidum, though obviously the 95% confidence interval there is very wide. We didn't see differences in white matter pathology or microbleeds. And I'm almost finished. So here are some representative images. You can see very nicely here. So in the column on the left is one of our donors who had an MRI. On the right is an individual who had normal cognition. And you can see this frontal temporal atrophy pattern, as well as hippocampal atrophy. And then neuropathologically, again, these are the same donors, and you can see really clearly the frontal atrophy here. and then the hippocampal atrophy here, both on the MRI and neuropathologically. And then we also looked at the relationship between tau pathology and atrophy. And we saw that both on the MRI scans and at autopsy, we saw a relationship between tau pathology and atrophy. And this was largely driven by relationships in the frontal lobes. So our conclusion, compared with men with normal cognition, those with CTE who were cognitively impaired in life had more severe frontal and temporal and hippocampal atrophy, as well as had increased odds of having the cavum septum pellucidum. And then we also saw that more severe p-tau pathology was driving the atrophy, or was associated with the atrophy, suggesting that it's driving the relationship. And we're going to take similar steps comparing AD and behavioral variant FTD to our CTE scans. And we also have an effort underway to characterize the white matter pathology using a software tool rather than by radiologist assessment. And with that, I will stop. I'm a few minutes over. I'd like to thank our whole team. A couple shout outs. Mike did a really great job on that MRI study and is a great colleague. Madeline Uretsky did a lot of work on that MRI project as well, and is leading the white matter project I mentioned at the end that she's working on with Mike. Nicole Saltiel designed a bunch of these slides that I presented and did a lot of the work on the CPC project. And then Alicia Chu, who is a biostats PhD student, did the really nice simulation work in the beginning. So of course, thank you to them and to our neuropathology colleagues who wouldn't, Anna McKee, Torstein, Russ Huber, who we couldn't do any of this work without them as well. And our funders, and then just some COVID humor. So we're rushing to get the vaccine so that we can go back and hit our heads. And with that, I'll stop.
Thank you, Jessie. I don't know if you have time, but if anyone has any questions. Anyone have any questions or anything?
I have a question regarding the symptoms and what seems like a decrease in the mood or some of the behavioral symptoms. And I was just wondering if there's any, you talked about selection in terms of, I think what was in the context of pathology. And I was wondering if there's any effort to control for someone's fear of what kind of the narrative around CT, which has largely been suicide and mood, even though that seems like that's thankfully maybe not such a defining feature. I'm just curious if there's any effort to kind of control for what people's beliefs are about the disease as you're interviewing their actual symptoms.
Right. So I mean, let me frame it a little differently. So I think, what's driving donation is symptoms, both the cognitive symptoms and the mood and behavior symptoms. And there's a lot of evidence that concussion and TBI and probably, these repeated hits are linked to psychiatric manifestations completely separate from a neurodegenerative disease, from CTE per se. So it's very possible that the reason some folks are joining the brain bank is because they have CTE pathology and the symptoms that are manifesting from that. and the folks who don't have CTE pathology are still having symptoms, and those symptoms very well could be related to their head injuries, even though it's not tau pathology per se. So I think that is why we may not be seeing differences in mood and behavior between the cases and controls, because we have this differential selection between cases and controls and mood and behavior. Your question about are we trying to somehow select against individuals who are concerned? I mean, we don't do much in the way of recruitment for the brain bank. It's mostly just word of mouth and people wanting to donate. I mean, I think it'll be a bit, I think that once we publish this paper that says maybe mood and behavior is less critical, and we see this new round of criteria where there's really an emphasis on cognition, that perhaps the narrative will change. But I don't know if that entirely answers your question, but it is kind of my thinking on the process.
Okay.
Does anyone else have any questions? Okay, if not, thank you so much, Jesse, for doing this for us today. I'm also going to email, I think it'll be best, I'm going to email out the event evaluation to everyone that attended. There'll also be a recording once it's finished downloading. It should be up by tonight. I'll also send that along in that email as well. Thank you.
All right, take care, everyone.
Thanks.
Yes, bye everyone. Happy holidays.